go ahead and get started. So welcome everybody to the Orthopedic Trauma Journal Club for calcaneus fracture. I am joined by moderators Dr. Thomas Reback from St. Louis University, Dr. John Hagedorn from UT Galveston, and my name is Arn Naja from University of Kentucky. We've got a pretty amazing lineup of faculty tonight. Dr. Roy Sanders from Tampa, Dr. Richard Buckley from Calgary, and Dr. Stephen Bernishka from University of Washington. These are the disclosures, none of them relevant to this talk. Just some general Zoom etiquette. All your microphones have been muted and the videos have been turned off. Please use the question answer for questions related to the discussion. Some of the questions we'll try and answer live. Others will be answered in the chat box. The moderators will review questions as they appear and present them to the faculty. So I think the way we've set this up, we're going to have the first video on Dr. Sanders' classification paper. That's going to be roughly about 20 minutes, followed by Dr. Bernishka's on the anterior process of the calcaneus, followed by Dr. Buckley's 2 articles on subtalar fusions and outcomes. Finally, we'll conclude those videos with some questions and discussion. I know that Dr. Sanders is currently attending the OTA annual business meeting, which is happening at the same time, but we have Dr. Buckley joining us, and I believe Dr. Bernishka is joining us as soon as he's finished with a case. Finally, we'll end up and wrap up around 9:20, 9:25, and there'll be 5 polls of questions to answer. The learning objectives for tonight's webinar is to understand the prognostic utility of the Sanders classification, articulate the importance of the anterior process of the calcaneus in open reduction internal fixation of calcaneus fractures, and then recognize patient and fracture characteristics that predict need for late subtalar fusion. So with that, we're going to discuss our first article, which is a highlight paper in Journal Orthopedic Trauma in 2014 regarding operative treatment of displaced intra-articular calcaneal fractures, long-term 10 to 20-year results in 108 fractures using a prognostic CT classification. Please feel free to enter your questions and we'll try and answer as many as we can. I'm going to go ahead and start. Thank you for joining us today, Dr. Sanders, to talk to us about your highlight paper, operative treatment of displaced intra-articular calcaneal fractures, long-term 10 to 20-year results in 108 fractures using a prognostic CT classification. So if I may begin, what prompted you to do this study?
Since 1986, really, when I started my fellowship way back in Vanderbilt with Dr. Swinkowski, I've always been interested in calcaneal fractures. When I came to Tampa, Dr. Helfet had recruited me, and Dr. Mass had just left, and Dr. Helfet was doing pelvis and acetabulum, and I was focusing more on lower extremity. And so back then, all the level 1 trauma centers were getting referrals from everywhere. And so I was doing about 70 calcaneal fractures a year. So given that, I started to evaluate them. And we came up with this classification system a long time ago. And we popularized a lot of different things. And now, with a mature practice, I wanted to follow up and see how those patients actually did. I wanted to see whether the classification was still valid. I wanted to see if the classification was able to be prognostic and tell both surgeons and the patients what they could expect with their injury. And that's why we did it.
Can you walk us through your algorithm of what you do for Sanders 1, 2, 3, and 4?
Sure. So the algorithm was pretty straightforward. We realized that a type 1 is a non-displaced fracture in this classification. And so that really just needs non-operative treatment, early mobilization, And once it's healed at about, depending on how much displacement there was, at probably 8 to 10 weeks, they can probably start walking without a problem in a boot and then progress. Type 2 is a simple fracture that should give you an excellent result, and that's an operative case. Type 3 is a little more complicated, and these fractures, if you have a skill set operatively, you can generally return them to almost pre-injury function. So type 2 and type 3 you can operate on surgically with a good result. And we can talk about what sort of an operation you can do. And then the type 4s are really type 4 and maybe more, right? So those are highly comminuted fractures that really get destroyed. And in those, we really followed Dr. Pennell, George Pennell from Toronto, his ideas from the 70s, which is to fix it anatomically and then go ahead and fuse the subtalar joint. So they really at 3 months, they're completely healed and they can go back to at least some function without being disabled and debilitated for months and months and months. And that's our algorithm.
Follow up to that, questions along the same line with the subtypes for Sanders 3. When are you considering fusing it all for Sanders 3, or are you always fixing them?
So I think that with a type 3 fracture, the real question is whether you can do it through a sinus tarsi. And honestly, I'm not that good in doing that. I'm obviously more facile with the extensile, but a lot of these patients come into my office anyway late. So I think that if you are comfortable with the extensile comfortable with the sinus tarsi, and you can get these people right away, you can try to get them and do an operative repair through the sinus tarsi immediately. But I will tell you that we got CAT scans, and it's either just been published or it's being published, where we looked at our type 2s and our type 3s with a sinus tarsi. And the problem is that if you get a plain x-ray, it can cheat a little bit for you on the Broden's views, and you can't quite see the joint reduction if you're not doing it completely through an extensile approach. So some of these look all right on a plain film, and when you get the CAT scan, you can see that a type 3 with a sinus tarsi approach is not perfect. But I know, and I know that Steve Benershka would agree with me, that if you do an extensile approach, you can get these anatomic if you have the skill set and are interested in learning that type of a surgical procedure. So I never fuse a type 3 unless there's no cartilage left. So sometimes you can put these pieces back together, it looks great on CAT scan, you're ready to do it, you open them up, and all the cartilage has been completely sheared off the subchondral bone. There's no point to that because these people are going to get rapid arthritis. And so in those cases, I'll go ahead. Again, it's very important to understand that you have to fix them anatomically so that you have the shape, the length, the height, the alignment. And at that point, you can then go ahead and denude the rest of the cartilage and then fuse them. You can't just go ahead and fuse them because they'll be misshapen. And that's not appropriate for a primary fusion.
Great. You told us about your algorithm, but can you also tell us as to how you counsel these patients based on their classification, their Sanders classification?
Well, it's pretty much the same thing. So a type 1 that's non-displaced, if they adhere to your treatment method, which is not always the case, they should expect a perfect result. With a type 2 and type 3, and more with a type 2, obviously, if you're able to get an anatomic reduction and you can verify that on CAT scan, I tell them they should have really an excellent result initially, and for quite some time, though I never know how much impact they had at the time of the injury, and so they can get cartilage wear down the line. So I tell them at that point, maybe 5, 10, 15, 20 years, which is what I looked at in this study, they may develop subtalar arthritis. And if that's very significant for them, then they would get a simple in situ fusion, and they would notice, and this is, progression from 2 to 3, they would notice stiffness in the subtalar joint, difficulty with uneven ground, cutting, running. They'd start to have problems there in the subtalar joint. And with the type 3s, I tell them it'll probably happen sooner than later, but at least they're shaped and they have more function than if I were to go ahead and do a primary fusion. And the type 4s, I tell them they get a primary fusion, they should be able to go do pretty much everything, but they probably can't run and jump, and they probably going to permanently have problem with uneven ground. It's important, I would say, that when you finally do the fusion, that you don't overcorrect them into varus, because people hate varus, and a little bit of valgus seems to be neutral for most people. So if you're going to cheat a little bit of valgus. Don't try to overcorrect them, because they'll fall off their foot when they try to walk sideways, move sideways. They'll fall because they don't have that eversion, and you have to build that into the fusion.
Great. Although you excluded from this study, can you tell us your preferred treatment modality for open calc fractures and extra-articular tongue-tie fractures? I know I'm kind of...
So there have been many papers on that, and we had a paper on that as well. I don't think I do anything differently. Basically, if you have an open medial wound, it's not so bad. It's usually where the sustentaculum or body fragment, pokes through. Obviously, if it's a degloving injury, that's a whole different story. That's like a, transcalcaneal tailnavicular dislocation. That's a whole different story. But if you have a poke hole on the medial side, you should be fine. It's the same thing with blisters. If you have blisters, if they're white blisters, it's not a problem. If they're red blisters, again, you have to be more careful. Again, if they're on the medial side, it's probably safer. If it's on the lateral side and it's open, if it's a gash, like a laceration, it's probably okay. If it's a degloving injury, all bets are off, because that's a soft tissue explosion, and the bone is the least of your problem. And I think that, again, Dr. Panershka wrote a paper, the folks in Seattle wrote a paper where they and this is what we do as well, you can shape that calcaneus with K-wires. K-wire jail, get the tailnavicular joint, pin it to the talus as well, and reshape it. And then just wait, let it heal, let it scar down in an anatomic position, pull the pins, let them walk on it. It'll harden. And then when they have arthritis, they can get a subtalar or tailnavicular and subtalar fusion electively, and then you have something to work with. So most of the open injuries are type 1 or type 2, occasionally a type 3A somewhere not around your incision, and you can go ahead and do that, but I wouldn't do it for a 3B degloving type injury.
And then for the extra-articular tongue-tie fractures, did you?
Yeah, so they're actually really hard fractures. So there are extra-articular tongues and intra-articular tongues, right? And the intra-articular tongue, we struggle with a lot. Sometimes you have to do a Strayer procedure on them, but you can't always get it up. Like, you can get it up, but it'll translate on you because of the Achilles. And when you're doing an intra-articular like that, if it's not fresh and you're having difficulty, then what I typically do is I'll do an osteotomy, and I turn a tongue into a joint depression, and then I line it back up. And with the osteotomy being oblique, it'll kick back into place, and then the plate goes on. So that's pretty straightforward. When it's extra-articular, that can be really problematic, because we wrote a paper I think a year or two ago, where they don't do so well. They pull apart. You put two cannulated cancellous screws down into the plantar surface, it'll rip right off. So you definitely have to do a Strayer. You probably have to put these people in a little bit of Aquinas and then walk them up over time. But the fixation falls apart if you use what do you call them? Tight ropes. I've used 2 tight ropes. They've fallen apart. The thing that works the best for me is this technique from Hardy Weber's book from 1983 on special techniques, where he actually uses a tension band. He runs a tension band from a lateral side, he runs it around the tuber, and then he makes a small incision medially, and he passes it back under, and then he ties both sides down, and it's a tension band. And the picture he has is a crocodile's mouth, and you can't open it. And that's really the technique, honestly, that's worked best for me, because they can't move it. And for an extra articular, that's pretty much what I'll do, even though that's, I don't know, 50 years old now, close to 50 years old, it still works.
Great.
There's
Thank
nothing
you.
new in orthopedic.
You noted about 100% of patients with Sanders 2 and 3 demonstrated radiographic evidence of post-traumatic arthritis, but yet only one-third underwent fusion, predominantly the Sanders 3. Have you noticed in your practice any patient-specific variables that lead to better clinical outcomes, such as
it's
education?
pretty interesting. So over the years, my partners have kind of pushed me away from acute care, and I end up doing a lot of reconstructive work. So I see a lot of patients that have arthritis in the foot and ankle, and we don't treat x-rays. You shouldn't treat x-rays. You can, obviously, if a patient has a problem clinically and it matches the x-ray, or the x-ray matches a clinical problem, then you have a cause and effect. But there are a lot of people that you look at their x-ray and it's just horrific. And you say to them, well, you know, how's your ankle? And they say, fine, I came into you because I got a hammer toe. Or I came in because I got a midfoot pain, you know, and a posterior tibial tendonitis, a true unrelated. So when I look at these x-rays in this study, after 10 to 20 years, all these people had a varying degree of subtalar arthritis. And remember, we got CAT scans on everybody. So they may not have had the arthritis on the x-ray, but when you look at the CAT scan, you can see changes, right? But clinically, the simpler fractures didn't really have any of the problems. And I suspect, I mean, that's pretty obvious, right? They have more cartilage, less cartilage was damaged. They only had a 2-part fracture. It takes a lot of energy to create a 3-part fracture. And so that extra energy probably obviously destroyed the cartilage of the subtalar joint. And so these people probably have more rapid arthritis. It's clinically prevalent than not. And so that's why I'm being honest, right? Everybody's got, at 20 years, all these people can have arthritis, but it's a varying degree of arthritis, and the people that seem to have the clinical correlation are the ones with a higher grade injury. And that really just, again, this classification has now stood the test of time. I have to say, when we did the original classification, we were just trying to help each other figure out how to operate on these and what worked and what didn't. For me to be able to go back at 20 years and see the outcomes and see that this classification still has merit and still is prognostic was really a little mind-blowing for me. I was very humbled by that, because it's you know, just pretty amazing that it works so well for all of this. It really does. It's quite amazing to me.
Yeah. You briefly mentioned on this, but let me just ask one more time. I really enjoyed your debate with Dr. Tornetta a couple of years ago at the OTA. But what role does the sinus Tarsy approach have in your practice? Do you use that at all, or?
Sure. So they gave me the Extensile, but I try to stay current, obviously, and we try, you know, if it's the right patient and the right fracture, we'll do acute pilons, we'll do acute, talus, obviously, we'll do acute calcaneal fractures if they're simple. And the paper that we published recently, or it's coming out in JOT, is that with a 2-part fracture, If you can get to it, I don't know, within 3 to 5 days, with a sinus tarsi, you can pop it, you can see it, you can manipulate it, and you can get a very nice result very early and allow early motion on these people. The problem with doing an extensile is that you have to wait till the swelling is down. And even then, you still have some soft tissue problems in the corner with apical wound necrosis. And obviously, people don't like that. The other problem is, by the time you do it and you're at 2 or 3 weeks, the fracture can be very stiff, can be starting to heal, and you can't always get the length out of it. And so these people, because you're doing an extensile, the subtalar joint tends to be a little stiffer than if you do a fresh fracture through the sinus tarsi. Now, saying that, there are 2 caveats. The first is that it requires a learning curve to learn the sinus tarsi, and the sinus tarsi will work for simple 3 parts, but not for every one of them. And if you wait too long, you'll never get a good result. And if you don't get a CAT scan, you're just lying to yourself. That's number 1. And number 2, if all you know how to do is a sinus tarsi or one-trick pony, and you're going to fall into problems, because if you get these things late, you have to know how to do an extensile approach. And if you don't, and you do a sinus tarsi, you're not doing the patient a service. So what I would say is that if you're gonna, as an orthopedic surgeon who is interested in trauma or foot and ankle, if you're gonna do a sinus tarsi, you better know how to do an extensile, right? It's just like if you're a sports guy, you know, and you're doing a shoulder, you better know how to do an open shoulder as well as an arthroscopic shoulder. You need to know everything and have everything in your armamentarium so you pick the right operation for the right fracture pattern. And I would tell you that for a type 2, easy, early sinus tarsi is fine. But for a comminuted fracture or late, or you want to do a primary fusion, you really need to know how to do the extensile lateral and keep yourself out of trouble. So with both of those, that will really help you be a consummate calcaneal fracture surgeon.
Great. Thank you for sharing that wisdom. Final question. So kind of to wrap this up, what questions do you think still remain unanswered in the topic of operative treatment of calcaneus fractures?
Well, I think that if we could get a better a way to get the sinus tarsi approach to give you a more visualization, so maybe a longer, maybe an old Coker, you know, the way we used to do this originally, so just for 1 minute, right? We used to do this with a Coker approach along the perineals, and you could see the whole joint, but you had to move the perineals up and down, and sometimes you dislocated them and didn't quite understand what we were doing. And Diego Fernandez used to do a limited Coker approach, but he would put the patient prone so he could go medial. And so he was able to reconstruct the body with a medial plate and a medial reduction, and the joint through the lateral approach. And so I think we're gonna, once everybody's comfortable with a sinus tarsi, again, it's another learning curve, then people are gonna say, well, I can get the joint, I can't get the body, how do I get the body? I can go distal, I can go get the interprocess, but I can't quite get the body where I want it to. And so people might then start doing, you know, just like you do for tibial plateau, just like you do with a pelvis, right? We're constantly pushing the envelope and coming up with a perfect solution to all the aspects of the fracture. And I think that's what you're going to see, you know, dual approaches for calcaneus. And you probably will be able, because I know I've done it several times, you're able to get it perfect. I mean, really, it's quite amazing. So I think that's ultimately where we're going to go. And if you can do that, then you don't really have to worry about the soft tissue envelope, which is the real key to this whole operation.
Great. Thank you for taking time and sharing your wisdom with us, Dr. Sanders.
Happy to do it. I thank you very much. I enjoyed myself.
All right. With that, we're going to go ahead and go to our second article, which is the prognostic value of computer tomography classification system for intra-articular calcaneus fractures by Dr. Bernishko and et al.
There was the classic descriptions of calcaneus fractures were usually lumped into two basic groups: tongue variants and joint depression injuries. And there were classification schemes that were just based on that, really not on the fracture line. Then there was an attempt thinking that if you classify the number and the location of the fracture lines of the posterior facet, that had some prognostic outcome, and turns out that doesn't, because it turns out really what's more important is the fracture line location is directly attributable to how difficult the fracture is to reduce, not necessarily that it's going to do badly. In other words, a very medial fracture line of the posterior facet is more difficult to see well. And then a segmental injury to the posterior facet, it obviously matters on how well each section is reduced. And what became clear when we were looking at any of the classification schemes before, nobody really talked about they just talked about the joint. They didn't talk about the rest of the morphology of the heel. And essentially what we realized is that once you take into consideration all the fracture fragments, especially the anterior process, you realize that that's actually the crux of the reduction, is reducing the front, which is really distal to the critical angle of Calcaneus. In other words, just distal to the posterior facet, because that always gets driven up into the sinus tarsi, lateral to the talar head and neck. And unless you bring that anterolateral fragment or the anterior process down, depending on how comminuted it is, that is really the lighthouse to the subtalar joint. Because if it doesn't get brought down essentially inferiorly or planarly and back to where it should go, then the talus cannot articulate with the posterior facet properly, because literally, essentially what you are accomplishing is what I was talking to you about today, is the subtalar joint gets seized. In other words, you cannot pronate the foot because the front of the talus has no place to go, because the anterior process is literally blocking its ability to move in the coronal plane, based on and we basically were trying to illustrate that where the fracture line does occur doesn't really matter. It's a matter of the most common problem is the anterior process, or the most difficult reconstruction is the anterior process. And so the articular reduction is part of the problem, but the main dilemma is the whole shape being restored. In other words, the length of the front, and then the tuberosity is kind of the last stage. You fix the front, then you fix the middle, which is the joint, and then you fix the tuberosity at the end. Whereas classically, everybody started from the middle, and the problem is the anterior process is the key to the whole fracture, which most people don't even nobody talks about the anterior process really. Well, I think because the Sanders classification really only talks about the posterior facet, it doesn't talk about the relationship of how that fits with the rest of the morphology of the heel, meaning the tuberosity or the anterior process. And so, when you see the fracture classification, it doesn't distinguish between joint depression and tongue variants. All classification that I was using was Lichter's classification, because he wrote a paper about the number of fragments in the anterior process. I mean, I can send that to you, but we call it a Lichter 1, 2, 3, or 4, because he was the one that actually was the only one that ever actually even talked about the anterior process in the 80s. Once you get the anterior process down, the cuboid follows that. And so essentially that indirectly has a direct bearing on the outcome of the fracture of the calcaneus, because that also is pivotal with respect to Chopard's joint. In other words, the the Simon line between the talar mandibular joint and calcaneal cuboid joint. If you bring the anterior process down where it should go, the lateral column of the foot is reestablished. And if you don't bring the anterior process down, almost by definition, what ends up happening is the cuboid follows that malalignment, and the foot essentially is starting to go flat. In other words, the lateral column is short by virtue of the anterior process being truncated, shortened. And so once you restore the length, which involves the fracture lines of the anterior process, and the more line. In other words, when you get shortening and then you overcome shortening, there will be many times cortical reads on the superior part of the anterior process that actually it's properly realigned, and you get an AP of the foot, or you can see the best way to understand it is if you look at a pre-op lateral of somebody that has an unfixed fracture, you can never see the middle facet, because middle facet is a medial structure and the lateral part of the anterior process is above it. And so it obliterates your ability to see the middle facet. When you bring the anterior process to length and inferior, you essentially bring it out to length and inferior, then all of a sudden you can look through the sinus tarsi and see the middle facet, which really essentially tells you that you are getting the lateral column down where it should be. I don't know, 20 years, we didn't really have good implants to manage a very comminuted anterior process. So we would reassemble the fracture fragments, and then because the anterior process was comminuted and we didn't have locked plates to hold the front down well, we would put the plate that we fixed the heel with was extended out onto the cuboid. So in other words, you would anchor, you'd be holding the anterior process down by virtue of being anchored properly to the cuboid, so that you restore that calcaneal cuboid architecture, but unfortunately spanning the joint. And you'd have 1 or 2 screws in the cuboid, and then you 6 months later, to free up their calcaneal cuboid joint, you cut the plate off or take a screw out. And then as soon as, a lot of people say, well, the anterior process is too comminuted, you can't fix it. Well, this allowed us to get it realigned, but the problem is it does bind up the calcaneal cuboid joint. With the advent of lock platings, especially the newer lock plates, not necessarily the older ones. The older ones were pretty rudimentary, but the whole point was that you would be able to contain the anterior process position without having to go to the cuboid.
Great. We'll finally discuss our last 2 articles by Dr. Buckley, Displaced Intra-Articular Calcaneal Fractures Variables Predicting Late Subtalar Fusion, as well as a OTA highlight article discussing open reduction internal fixation compared with open reduction internal fixation in primary subtalar arthrodesis for Sanders type 4 calcaneal fractures, a randomized multi-center trial. Please feel free to keep putting in your questions, and we'll try and answer as many of them live with Dr. Buckley and Dr. Bernishka at the end.
Dr. Buckley, thanks for joining us.
Thank you.
So we're going to talk about 2 papers today. One, as you can see up here, is from 2003. Dr. Buckley, would you just kind of describe where this idea came from and how this idea was spurred on?
Well, this paper was generated in 2003 from data that we had created through the 1990s. And so in 1991, our Canadian Orthopaedic Trauma Society was begun. Myself and Ross Layton, Bob McCormick, and Bob Meek, and Dave Petrie. And really, we put this together with a randomized controlled trial of operative versus non-operative care of calcaneal fractures. And that trial ran through all of the 1990s. And by the time everybody had 2-year follow-up, we sort of made the year 2000, presented it through around 2000, 2001, and basically determined that we had really scant differences between operative and non-operative care in a huge group of calcaneal fracture patients that will never be done again, that study, because we just can't treat them non-operatively. This particular paper then was an offshoot because we looked at all the variables that would predict late subtalar fusion in this huge group. I think it's about 470 calcaneal fractures. And so this paper then really helped us move in on what were the patient characteristics that determined someone would have a bad outcome, whether treated operatively or non-operatively, such that they'd need a late subtalar fusion. But back in the 1990s, we didn't have good evidence that operative care was the way to go with calcaneal fractures. So once we determined that operative care was probably marginally better, especially in some populations, we could proceed with this particular kind of review of our huge database. And what we found was there were certain patient characteristics, males who did heavy labor jobs. And so that was two crucial things, because when they had a bad heel fracture, especially the higher grade Sanders 3s and 4s, they had a much higher subtalar fusion rate. The people who had an initial Bowler's angle, which was much less, so 15 degrees, pretty good. It's not badly displaced. Those people had a very unusual late subtalar fusion rate. And then there was a few other things. Workers' compensation board patients, they just tended to have less and less ability to handle calcaneal fractures and heavy labor after, and we're much happier with subtalar fusions. And then lastly, one of the most important things we found is that, look, when you had a subtalar fusion, everybody sort of caught up to the best results that you could give them if they were treated non-operatively or operatively and were not doing well. When you fused their subtalar joint, they kind of caught up and were really doing not badly.
So you report roughly a 10% fusion rate. If you're treated non-operatively, about 20%, and then if you're treated operatively, about less than 5%. In your practice, who gets treated non-operatively and what percentage?
Yeah, thanks, Thomas. That's a really good question, and I've had to justify this for my whole career now, having been involved as the major author in this big randomized controlled trial. Non-operative care has a place, and that place is in people who are just poor surgical candidates, and especially older poor surgical candidates, and especially non-compliant older bad surgical candidates. So when you add up all those features, it's the bad medical patient, the older patient, that patient who doesn't have a bad subtalar joint, their Bowler's angle is 15 degrees or higher on initial presentation. The really non-repentant smoker, these people, when you add it together, just don't do well with surgery. Now, on the other side is if you have bad foot shape, those people must have surgery. And I put foot shape ahead of bad joint congruity, because really we found that, and that was something that didn't come out in this paper, but has sort of come out since, anybody who's got a malformed foot will do poorly. And then that makes for a very difficult late fusion. And so your question, Thomas, is important, is that those people who have good foot shape can also be treated non-operatively. We can predict who will do poorly with non-operative care based on our criteria. So if you've got a Sanders 4, right away you know that you probably have poor foot shape. You already have a joint that has been very badly influenced, and its future has been determined to have early arthritis. And so putting those together, I would say that that person mandates having surgery, whether you proceed with an operative reduction, if that's something that you do, and if you don't, send them to somebody who does do operative calcaneal reductions, or a primary fusion, because our second paper really shows that a primary fusion prevents the two operations, having to do one operative reduction and then a later fusion versus just doing a primary fusion, which patients will do well. And a good thing about a primary fusion, heals up more quickly and they can start weight bearing more quickly. That's something that I think most calc fractures, when you do them, they need an extended period, at least 8 to 10 weeks While most fusions, after 6 weeks, you've got a solid fusion and you can start walking. So I think that's an advantage.
Okay. So it kind of dovetails into our second paper regarding primary fusion. If you could just briefly describe where this idea came from.
So this paper was generated after we had done our randomized controlled trial and after we'd done our paper that we presented first there. And we had learned by this time with our Canadian Orthopaedic Trauma Society that our calcaneal fracture patients, the worst, the type 4s, had a high fusion rate. Yet no one had done that paper, operative versus primary fusion, for calcaneal fractures as a study. And we thought we'd be able to generate enough within our group. As it turned out, a randomized trial was very tough, even though we had 4 real good centers operating in this group. So that was the impetus, because we knew that we didn't have an answer, yet we'd had enough cases under our belt at this point, and all of us were real calcaneal fracture surgeons. We knew we had the expertise in the group that we could do this study. So we proceeded down the line, and there'd been such a paucity of literature before about the Sanders 4. So he said, well, let's do it.
Can you just comment on how doing this paper led to additional, evidence-based articles regarding the management of Sanders 4 fractures?
Yeah, thanks, Thomas. I think it actually is a pretty significant paper, because with quality surgical care, with those of us that are involved in the study, and with a real tight group, and these are the Sanders 4. These weren't the simple calcaneal fractures, so we really had tailored it to the worst of the worst. And then when they're randomized to a fusion or to operative care, generally these patients did quite well, but we found that the results were equal. And in certainly my mind, there is a group of Sanders 4 patients that will then go on to late fusion. We didn't have that many in this study because we didn't have a lot of patients overall, but we know that the Sanders 4 occasionally will go on to second surgery, meeting a fusion. Why not do that primary fusion? And certainly if you're dealing with a tough patient, and by tough patient, I mean maybe somebody who not necessarily compliant, somebody who's potentially a smoker, workers' compensation, they have a high rate of needing a fusion later. Why not just do one simple operation and help both you and your patient to get through this terrible, nasty insult? Now, importantly here, Thomas, a lot of people, they skip this part of the study. If we did an open reduction, that was through an extended lateral, full operative intervention. If we did the fusion, we still did the full operative intervention, but then took the joint away and fused it. And so these aren't I'll use the term half-assed surgeries. These were full open reductions followed by fusion. And I think that's necessary because we still are trying to get good foot shape. And I'll put in a plug now for operative reduction. I think by doing extended laterals, we really can create really good anatomic feet with height, length, width, all restored. I'm not a aficionado of the sinus Tarsy approaches for doing difficult fractures, because I don't think we get height, length, width correct as easily unless you're really, really slick surgeon. And so this is where I believe in some instances we have to do a full operative intervention to get these bad feet, the type 4s, get them correct. You know, these people do well. What we've learned with this particular study and even our initial randomized controlled trial was that a late fusion is not a bad outcome. A fused patient does really quite well. We know that the best patient will have subtalar motion if they've not been fused, and that is a real harbinger of their late outcome. Now, there's more motion you can restore, and that's why the percutaneous reductions are slightly better now than the full open, because they have more subtalar motion if you've done a nice reconstruction. So more surgery means more stiffness. But if you've done a good fusion, you've taken their pain away, so they can live with a little stiffness and it'll be accommodated through the rest of the hindfoot, midfoot, and ankle. And so a fusion is not a bad operation. It just has to be done well.
Mm-hmm. And so we'll close. The last one of the last sentences in this paper says the best treatment option is to fit the patient, not the fracture. And what are your comments on that and that statement?
Yeah, thanks, Thomas, for closing on this, because this has been something that I've really believed in for my whole career. And coming from Canada, this has been something that I think we've helped spread the word about evidence-based medicine, is that higher evidence leads to better decisions. And so the three things that make up evidence-based treatment: number one, what the patient wants, what the patient deserves because it's their foot, and what their feeling is. Because some people say, oh yeah, fuse me, doc, and get this over with, but it's the patient thoughts. Two is what the surgeon can do. What are you capable of doing and doing well to the best of your ability? And thirdly, what the evidence in the literature shows. What's the latest and best evidence? And certainly that's where we have to put the level 1 evidence and the multi-center trials and those systematic reviews and meta-analyses to the top. And we have to follow this, because we're not, none of us are better than anybody else. But as a group, we're going to move forward with higher level evidence.
Well, I'd like to thank you, Dr. Buckley, for joining us, and thank you for providing your insights from all your years of experience.
Well, thanks, Thomas. An honor to be here. And
Dr. Buckley.
All right, so with that, I'm going to stop sharing. I'll ask Dr. Buckley and Dr. Bernishka, as well as Dr. Reback, Dr. Hagedorn, to turn on their videos, and we can quickly do some question and answers from the audience.
So the first question that came up is, what are the indications for percutaneous fixation of calcaneuses? That's the first one to pop up. Dr. Bernishka or Dr. Buckley?
Can you hear me, John? Can you hear me?
Yes, sir. Yes, sir.
Well, that's a good question, because I think a lot of people would like to do things more percutaneously, recognizing even what Rick just alluded to in his discussion about Sanders force. The big issue is percutaneous reductions really only can be used to facilitate reducing a tongue variant injury more anatomically. The problem is you can unlock its and derotate its position, but it's very hard to maintain it with, for example, percutaneous screws, because the forces are such that it's very easy for that to redisplace in its depressed position, because as I was talking earlier about the anterior process, really high energy tongue variants usually go along with a very comminuted anterior process. So to reduce the fracture is one thing, to maintain its reduction is the second. And so we noticed this long ago before locked implants, that if we didn't have a better way of controlling the tuberosity, we would get essentially insidious progressive failures even after fixing them, because the fixation wasn't able to hold on long enough. We do percutaneous reductions all the time for skin at risk calcanei. These are almost all tongue variants, so posterior skin at risk. And those in our hands now at our institution, what we're doing is all the trauma faculty will percutaneously realign displaced skin at risk fractures, hold them in that position, and then we definitively go back and fix them, usually with an extensile approach sometime later, 10 days to 2 weeks later. The one indication for true percutaneous reduction is the extra-articular tongue, which you can reduce acutely with just clamps and, for example, screws. In our hands, we have a very hard time accomplishing that without releasing the gastroc at the same sitting. But the point is that to obtain a reduction, you can do that with a percutaneous clamp or reduction tools such like a Weber clamp to control the displacement. But intra-articular reductions is very difficult to do percutaneously.
So everything that Steve says is right on. I think all three of us are saying so many things the same, but I like to break it up into the patient reasons, the fracture reasons, and the limb reasons. And so percutaneous surgery, I think, really should only be used in, for example, with patients that are just not healthy enough in relation to their skin quality, heavy smokers, patients medically not well, as far as the limb, those areas where you just have really bad skin and you're just looking at foot shape and the joint isn't nearly as important, diabetics. And then lastly, in relation to percutaneous surgery, Roy said that, Steve said that with his talk, and really me with mine, is that we should only be taking on simple fractures for percutaneous fixation, where you have the best chance of getting it right. You're not going to take a bad 3 or 4 and try to do that percutaneously, because you're wasting your time. You're just not going to do it well. The sinus tarsi, if you add that now to the percutaneous, where you've got a small cut, you might be able to see the joint and get it right. So I hope those words of wisdom help you remember the patient, the limb, and the fracture.
What size screws are we using with percutaneous fixation?
So usually for me, sorry, Steve, I'll just finish here. Yeah, usually it would be a cannulated 7.2 or cannulated 6.5 screw. And those are screws that you carefully place with lots of views under fluoro once you've got it. And you need screws that both support underneath the joint, screws that support longitudinally, and screws that will help so that your overall shape is determined. So you need them in multiple different directions in areas where the skin's not compromised.
We're using smaller screws only because the pitch of the smaller screws can capture more parodic bone. But I think the main thing is whatever you're putting in shouldn't be a prominent structure later. For example, if you're trying to do something percutaneously, the screw should not be a bother to the patient later. Probably the biggest thing that we're finding now is people are, and Rick alluded to this with the Sinus Approach, people are trying to do sinus tarsi approaches for even moderately complex fractures and not even getting them close. And then what we have to do later is they all get the same deformation patterns. They get short, they get wide, they're in varus, and they're usually very overloaded in their perineal sheath area. So they all get impingement. And then when you want to do a fusion, you have a very difficult time doing that through a sinus tarsi approach because you can't really correct the morphology. So that's why it's pretty pivotal in the really complicated fracture. People want to stay away from getting involved, but in fact, those are the ones almost you have to get involved if you want to save their foot, because you can't do any good reconstructions later with a horribly malaligned foot. And we had a paper in 2006 showing how hard it was to correct with a subtalar fusion a malunited fracture, which now we're obviously doing different things, but back then we didn't have the tools to do that we do today.
Yeah, and so Steve, if I just add one thing, Steve is so right with this, is that we've gone through the pendulum. We started off non-operative care, and then, okay, operative, non-operative, now which is better? We learned, okay, we should be operating on them. Well, then we go whole hog with great big extended type incisions, but now there's soft tissue complications. And so, okay, now we back off and we're back to, well, we can't get things maybe quite as perfect with an extended lateral, but we're helping the soft tissues. But just like Steve says, when we did the extended lateral, we could get it right. Roy said that, I get him right, Steve will get him right. But as soon as you move towards having a smaller cuts, more percutaneous surgery, we really risk getting foot shape and the joint right. And now we've got malaligned, misshapen feet, and the joint's not good. And so the pendulum swings back and forth. It's in between, which is why you have to be so careful with these.
I'll just say one thing. Rick kind of alluded to this. You know, everybody gives us a hard time about doing extended approaches, but what's interesting is that now I'm seeing a whole host of sinus tarsi approaches that come to us infected. They're malaligned. They only can have a fusion. They have a sinus tarsi approach that's draining, and there's no reduction. And so essentially, you have the worst of both worlds because you have no reduction, you have an infection, you need to do a fusion, but you really can't do one because the patient's infected. So you're doing another operation, try to get them clean, close, and dry before you fuse them. And so we're actually going to try to submit a paper. We call it the sham incision paper, where we're making the extensile incision, not elevating the flap, and then waiting 6 weeks, going back 6 to 8 weeks later, knowing that the flap will survive, to go through that to do an extensile approach to realign the foot, because we know we can't do it through a sinus tarsi approach. So it's distressing to see, but it's almost exactly what's happened is people are choosing what they think is an easier path, but they're making it a much more difficult one later because they don't take care of those problems and they send them to people like us and they want us to fix them, and it becomes incredibly more difficult and trepidatious for the patient.
Dr. Murderska, can you comment on acute external fixation for a widely displaced calcaneus fracture?
You know, well, I started doing that a long time ago because when I wrote up the series of wound complications, we didn't really have many wound complications with closed fractures, but the open fractures, because the medial wound was the one that was always at risk or had issues with healing, and many times they would take months to heal. I realized if I realigned the tuberosity's position in space acutely, it made the medial wound accessible to be closed primarily. And instead of just reducing it, then holding it in that position, I put a 3-prong frame on, basically from the tuberosity, then to the tibia, and to the midfoot, through the cuneiforms. So it was like a triangle on the medial side. And you would realign shape, you close the wound medially, you don't do anything on the lateral side, and indirectly, kind of like what you would for a plafond injury, you would reestablish all the morphologic reconstruction you need: height, length of the tuber, shift of the tuber medially, anterior process length via the anterior process fixation to the cuneiforms. And then you go back 1, 2, 3 weeks later, and the lateral incision is pristine. Nobody's gone through it. And I did that for open fractures for quite a while. And then I said, well, I had a guy who came in with a markedly displaced closed injury, did the exact same thing for his closed injury. He was really very painful acutely. I remember distinctly, he's a 70-year-old guy. He woke up in the recovery after I put the frame on. He said, my foot feels so much better. And because I think what we did was we had taken the tension off of his tibial nerve by shifting his tuberosity back medially and posteriorly, so it wasn't on stretch. And he said, this feels fine, because he was stable. And then, and the other sort of parenthetic thing we found was by doing that, complex fractures that sometimes take 2 or 3 weeks because they're swelling to be able to be fixed definitively would be ready in a week or 10 days, which is like what you see with, you fix the plafond by realigning the plafond, fixing the fibula, putting a good frame on. The plafond is ready for definitive treatment much earlier than if you had left it in its misshapen position. So that's what we're doing now. And we do it fairly frequently.
Another question is, there was a question about how to sequence the reduction of the anterior process and then the posterior facet and the tuberosity, and likewise, how you sequence the reduction if you're going to start with the posterior facet and then work on the anterior process and tuberosity. So there are just tips and tricks on that.
Who do you want to talk? I know.
Dr. Buckley, or either, if you want to go first, because if you're a joint first guy, or
well, I'm not
whatever you like there.
I mean, we would teach on the AL courses joint first for a long time, but what we realized as the fracture became more complicated, that you could not literally fix the articular surface of the posterior facet to the sustentaculum until you brought the anterior process out of the shortened position, so you could get access to the posterior facet, because the fragment would be so depressed in the sinus tarsi that you could not literally reduce the articular surface. So we started derotating the anterior process down and bringing the sustentaculum back and in the proper position, anchoring the anterior process. And essentially, when you do this sequence, when you get the anterior process right in terms of out to length, it actually confirms for you that you're doing the right order of realignment, because the posterior facet becomes very easy to then reduce, because you've got you can look at it position where it fits it to the critical angle, and sort of what you have to do is that you then realize the tuberosity is in your way in the back, but you've got the front realigned so that you then manipulate the tuberosity to get it out of the way of facilitating the posterior facet. And when the posterior facet is keyed in, then it corroborates where you need to put the tuberosity. So each sequence sort of correlates with you're going in the right direction to get the morphology back. So that's why I go front, middle, back.
Yeah, I think Steve has taught us that, and he had been doing these just a few more years than before I started doing them. And, you know, we had learned from Steve. So I would agree. You still have to start after you've done the front. You still have to work way medial and then towards the back. The problem is that a lot of people call that sustentacular piece the constant piece. And That's not a constant
No
piece.
constant.
Okay, and Steve will know this too, is that medial side piece is not constant. And so a lot of people just build everything to that and think they've got it right. Well, that's not true. So if you don't get the front right, then you can't get that sustentaculum into the right spot, and then you can't build your posterior facet to it, followed by your posterior tuber. So you really have to work in sequence and in order. And that's why it's so tough to do things through a sinus tarsi. So I agree with Steve in relation to that. We have taught this course in Davos in Switzerland for a number of years, and it's 4 hours on one calcaneus. And what we prove is with the CT and all the different pieces, and all the different pieces are color coded, that you can see that medial sustentacular piece is also badly displaced and not in good position. And without working on the rest of the front and medial structures, you can't get that posterior facet right.
Dr. Buckley, at the Davos meeting, I heard something pretty interesting that you'd mentioned. Can you kind of mention again, like for the calcaneus fractures that you're treating, what percentage are full extensile, how many are sinus tarsi, how many are non-op, and what sort of time frame you are, and same for Dr. Bernishko? Yeah, so in my practice now, it's evolved as everybody does. But I'm about 10% non-operative, so the older medically unfit patients with not bad looking foot shape or joint. And then about 10% are on the other extreme. They're so bad that I proceed with the fusion, or they have patient characteristics, jumpers, people who have bad medical history. And then you've got that tough group. Okay, am I going to do a percutaneous sinus tarsi small incision surgery or a full meal deal? And I'm now down to just about 20% through a full extensile approach, and about the rest, it's closing in on about 60% with small cut surgery. But I have to say, your best chance of getting a perfect heel bone, and in the young patient, I have no issues with approaching a full extended approach to get that foot perfect by doing a full extended. Now, we operate quite a bit earlier than others. We've done so many in my institution that with the, as Roy had said, it's about 1 a week we were doing at the height of our study. When you're ready to get at that foot. So we're not waiting until they're sticky out at 3 weeks. I like to do them before 2 weeks. So usually at about the 10-day point, and most feet are ready for surgery, especially those that aren't badly traumatized. So that's sort of my plan. About 60% small cut surgery, at least 20 to 30% with the full extended, and then what's left non-operative and fused.
I would say, a majority of the ones we are fixing here through an extended approach. The sinus approach we're using, it's essentially an incision you make just above the critical angle. So you're inferiorly taking the perineals to see the anterior process. And the only ones I'm doing those for tongue variants, because you don't need to see posteromedially. In other words, a segmental injury to the posterior facet. You cannot see that through a sinus tarsi approach. So but for tongue variants, you can see the entire fraction line in evolution as you're reducing it. So I use it for tongue variants. So I'm using an extensile approach for most of the other ones. Unfortunately, for all of the really smashed ones, unfortunately now we get transferred a lot of patients that have open fractures, and they will come in and somebody has debrided their bony injury from the medial side, and they come without their posterior facet. And so they come with a big hole with a medial wound that somebody has done something to. And essentially, obviously, in that scenario, we have to do what Rick's talking about. We have to do our primary fusion. But what we're always doing in that scenario is fixing the entire morphology of the heel with a plate. And then we have a defect that is now where the posterior facet was, which we have to then strut out to the right height with positioning screws, and then using autogenous bone graft to get them to incorporate. And unfortunately, we get probably 3 or 4 a year like that now. But most of the ones that if they come to us from the very beginning, we're treating them in the fashion I just mentioned.
You mentioned the perineal tendons. Can you describe your approach to subluxed perineal tendons in the setting of calcaneus fracture, and how you approach them and how you fix it?
Well, you can see actually there's two versions. Some of them more rare have a ligamentous, in other words, there's a perineal sheath disruption and non-osseous injury to the fibula. If you look at a mortise x-ray on the ones where you have to be cognizant of looking for that is you'll see a little fleck on the distal posterolateral fibula, and that is the perineal sheath that literally has been ripped because the perineals have dislocated in front of the fibula in the process of this pronation injury that has occurred. And so if you reduce the fracture anatomically, you can imagine that you've now brought the ability for the perineals to be back behind the fibula where they should be. But I learned by seeing this fracture line that some of those will sublux. You can actually push them back with your finger and they will go back in the groove, but you've just done your extensile approach, and instead of making a separate incision to put a plate on that perineal sheath osseous injury, I wrote a paper on this, but we just push the perineals back and then put a series of 3 rafter or 4 rafter wires that hold the perineals in the right position, right next to the heel cord. And then at 6 weeks, we pull them on, and they've never redislocated. The more problematic one is when you come back late, if you're going to do something late and nobody's looked at that and they are already in the front, that is nearly impossible to reduce if you see them at a year and a half later when they've, and I talked to my mentor, Ted Hansen, about it. You know, he said, Steve, if they've gone in the front and they've been there for 24 months or 36 months, you're not getting them back, and you're going to be doing a fusion anyway. So don't burden them with another problem that they have to contend with. Just get them so they can have their foot on the ground and they're square and realign them properly. But it's a good, I mean, it's very important that you recognize it. I always show the fellows and the residents, when you're acutely exposing and positioning the patient, you will feel, or you can see subluxing tendons. You can actually feel them digitally reduce with your finger. And then I always say, look, now watch this. And then when we finish the fracture, when you close the skin, you'll see that the perineals are almost invariably reduced. If they're not, that's the one when you would pin them.
All right, unless there's any other questions, I was gonna wrap it up with some summary points as well as a survey.
We look good, everyone in the room.
You guys seen presenter mode, or are you guys seen the full screen?
Full screen.
See, I see you, but I just see Calcaneus Journal Club.
Yeah. Perfect. So these are the last couple of slides, and please stay to finish the polling questions at the end. So thank you for the moderators as well as the guest faculty that joined. Some of the take-home messages, again, the anterior process of the calcaneus is key to restoring calcaneus length, foot shape during open reduction internal fixation. The Sanders classification is prognostic even after 10 years, with type 3 fractures having a 4-fold greater need for subtalar fusion than type 2 fractures. A small percentage of operatively treated intra-articular calcaneus fractures require late subtalar fusion and may benefit from primary fusion at the time of operative fixation. Please keep in mind the dates for some of the upcoming journal club sessions. The next one's going to be on clavicle fractures on April 13th, followed by distal femur and distal humerus. So with that, Chris.
Arun, can I make one point?
Sure.
One point is, if you don't have expertise in these fractures, just like what Steve says, send them to somebody that does. This is one fracture, except if it's open, that can really wait until an expert looks at it. And those people who see a lot of these do a much better job. So please just send them in to us.
Great point, Dr. Buckley. If people can just finish and complete the evaluation.
I would agree with Rick. And the other thing I would add on is that probably the 2 fractures that demand utmost attention to all the aspects that we've sort of talked about with calcaneus fractures is the calcaneus that's markedly displaced and a plafond injury. And plafond injuries I think that's the most difficult fracture in orthopedics because of the complexity of the soft tissue envelope in addition. calcaneus fractures are tough, obviously, but I think the plafond injury, unfortunately, is a really problematic area because there's so many more of them now, and they really do demand. And we're just seeing the late sequelae, and if all the other things that you do in response to when they don't go well are not good options. So I would add that on as well.
Great. And the last slide, just keep in mind a link to the recording will be sent out through Zoom 24 hours after the conclusion of the session. And please subscribe to the AO Trauma North America YouTube channel where you can view this and other videos. Thanks again to all the moderators as well as the faculty for joining us.